My name is Dr. Payal Kohli, and I'm a cardiologist who specializes in non-invasive and preventive cardiology. I graduated from Harvard Medical School, and I currently own and run a general cardiology practice in Denver, Colorado. In this video series, we're tackling 5 common misconceptions around the use of coronary CT angiogram, or CCTA, in the diagnosis of coronary artery disease. And we'll be debunking some myths. This is the second video in our series. Another common misconception that I often hear that we'll be discussing today is that coronary CT angiography doesn't give me as much information as a stress test does. Let's go ahead and dig into why this isn't true. And I'd like to use some patient cases to help demonstrate just how much information a coronary CTA can provide more than a stress test. Now, both of these patients we're going to talk about today have stable chest pain and had previous inconclusive stress tests. They both then went on to have a coronary CTA. Patient A had diffuse, moderate calcified plaque of the RCA with a mid-segment stenosis of about 50%. Patient B had an LAD lesion with mid-segment calcified plaque, also with a 50% stenosis. At this point, due to the CTA, we already know more about the patient's coronary artery disease than we did with the previous inconclusive stress tests. But there's more we can add to the diagnosis here. We can add physiology with a test called FFRCT to the coronary CTA to better understand the patient's disease. So why does physiology matter here? Well, if these patients were sent to the cath lab, invasive wire pressure measurements via FFR would be performed to assess whether the lesions were hemodynamically significant. This is the gold standard for measuring functional disease, but it's an invasive procedure that has risk of complications. With a coronary CTA, on the other hand, you get the anatomic information, how the lesion looks, and then when an AI algorithm technology is applied on top of it with something called FFRCT, you will get even more information telling you the effect of the lesion and how it behaves. Let's take a step back and discuss an important concept to understand, that physiology cannot be assessed via anatomy alone. We've learned really important lessons from large registries like the ADVANCE registry, where approximately 5,000 patients were followed after a coronary CTA plus FFRCT and then classified. And ADVANCE showed us that stenosis on a CT does not always give us a clear-cut answer of how to manage that patient. For example, in the lower range of stenosis, let's say 30%, we'd usually put this patient on medications, not send them to the cath lab, and move on. However, 1 in 3 of these patients have functionally significant disease based on that FFRCT. And on the other end of the spectrum, in the higher range, say a 90% stenosis, this patient would reflexively be sent to the cath lab due to that high-risk stenosis. However, 1 in 4 of these lesions will be discordant with a negative FFRCT, especially in the LAD. Now, we could avoid sending this patient to the cath lab if we had done the FFRCT. So let's go back to our patient cases and apply FFRCT and see if the anatomy and the physiology correlate. The FFRCT analysis differs significantly between these two patients. Patient A's FFRCT showed a severe, physiologically significant stenosis in the mid-RCA with a value that abruptly dropped to 0.68 after the RV marginal branch. On the other hand, patient B's FFRCT was negative, with a value of 0.94 distal to the stenosis and beyond. The physiology that we now understand for these patients can help guide their treatment decisions. So patient A was sent to the cath lab and had the lesion treated with a PCI. Patient B was safely deferred and medically managed. With coronary CT angiograms, we can determine the degree of stenosis. With the addition of the FFRCT, we can then also see if a specific lesion is physiologically significant. And another analysis that can be completed with coronary CTAs is the plaque analysis. This helps the clinicians to see the disease before it progresses into something more serious. Seeing plaque and understanding what it's made up of actually enables clinicians to prescribe the correct medical therapies with a lot less guesswork. And adding AI-enabled plaque quantification and characterization of a coronary CTA can tell you how the plaque looks. It can tell you if the plaque is stable, calcified, contributing to artery remodeling, or if it's high risk and likely needs more urgent treatment. The plaque burden can then be quantified via machine learning and tells you where the patient falls on a nomogram relative to their age and sex-matched peers. This way, we can really understand this patient's risk from the plaque, which helps us then guide their treatment. And then based on this, we can say, I need to be more aggressive about your LDL goals, or I need to change lipid-lowering medication because that plaque is a more concerning, unstable plaque phenotype. All of this from ordering a coronary CTA. Now let's circle back to the misconception that coronary CTA doesn't give us as much information as a stress test does. I'm really confident that I've shown you today some evidence why this may not be true and how you get anatomic, physiologic, and plaque burden information from using a coronary CTA. This information from these analyses really helps me figure out who needs to go to the cath lab, who needs to intensify lipid-lowering therapy. Essentially, it allows you to have your cake and eat it too. And not only that, it can also impact patient management, what you do with their preventive therapies. So be on the lookout for other videos debunking other misconceptions regarding the use of coronary CTA. After all, we all went into medicine to do the best for our patients. This means keeping up with the latest evidence and changing our behavior accordingly.